Now that you've learned several point-of-care ultrasound or POCUS exams, it's time to put them all together into the RUSH exam. The RUSH exam stands for Rapid Ultrasound in Shock and Hypotension. And it's one of these exams that changes outcomes for our patients because it helps categorize shock. And by knowing what type of shock a patient has, we know how to treat them. And that can make all the difference in the world. This exam really came about because we wanted a bedside tool in the hands of the clinician that could rapidly reduce our differential diagnosis, help categorize patients who are the sickest ones we ever see. And this exam helped us do that. One of the earlier exams that was described was the UHP ultrasound protocol, and this was done by two of my mentors and colleagues, John Rose and Aaron Baer. And it just makes sense that by doing an exam that helps categorize shock, we can help make differences in patients' outcomes because it targets our treatment. It identifies those things that we can do early interventions on to save lives. The RUSH exam came out by Phillips Para et al., and it has a nice acronym that's easy to remember, and it helped further categorize this exam for all of us. So how you want to think about this is, how can I use the ultrasound to categorize shock? There's three main categories of body systems or body parts you got to think about. There's the pump, which is the heart, the tank, which is your blood volume, and then the pipes, which principally the aorta, as well as the large veins of the legs. Now let's take the first row, pump. So if the patient is in hypovolemic shock, what do you expect the heart to be doing? What do you expect it to look like? So you should expect it to be hypercontractile, and that's what's going to happen is that the left ventricle, and maybe the right ventricle too, it's going to be trying to squeeze out the entire blood volume because the patient's hypovolemic. And you're going to see the inner walls of the endometrium just touching every single time it squeezes to try to get that entire blood volume out. Now, how's that going to compare to cardiogenic shock? Cardiogenic shock is going to be the exact opposite, right? You're going to have a dilated, hypocontractile heart that's barely going to be moving at all. Compare that to obstructive shock. In obstructive shock, you're typically going to have a large pericardial effusion, although you might be have a tension pneumothorax as well. But in obstructive shock, the first part of the heart that is the weakest myometrium is going to collapse first, because what you have is fluid around the heart that the pressure just keeps increasing until it compresses part of the heart. And what has the weakest wall, weakest myometrium in the heart? Right atrium and right ventricle. So you're going to see those collapse when the heart tries to fill during diastole. And that's going to be consistent with obstructive shock. Distributive shock, it can either be hypocontractile or it can be hypocontractile. And that's because in the case of sepsis, you often have the heart trying to push out as much fluid as possible because you have this distributive shock process where all your vessels are dilated and you need more volume. But after a while, you get a cytokine storm, and that can just create cardiac dysfunction. And then the heart can be stunned and look like a heart that's in cardiogenic shock. So when we're evaluating the heart in the RUSH exam, we typically only do two views, the parasternal long view, which is great for looking at contractility and effusions. And then we look at the apical forechamber because it's another way to look for effusions and contractility, but you also want to compare the chamber sizes. Because as a etiology for shock and hypotension, you got to think about pulmonary embolism. So we're looking at left ventricle and right ventricle, comparing those sizes. And the right ventricle should really always be 2/3 or less of the size of the left ventricle. Now let's think about the tank. So your blood volume. How do you categorize your blood volume? One of the things we like to use is the IVC, or inferior vena cava. You can also look at the jugular veins. You can also look at fluid within the abdomen to see if the tank has a leak. So you do a FAST exam to see if there's blood coming into the abdomen. You can also look in the chest to make sure there's not a leak in the chest or fluid dumping into the chest. And that'll tell you if you have a leaky tank. The IVC, we used to think it really correlated well with right-sided heart pressures, but now we know that they may not be the case, so we really use the IVC's extremes to help guide us. So if the IVC is extremely distended and does not have any variation with respiratory movements, then probably you're in a volume overload state or an obstructive shock state. Whereas the IVC is very small and collapses every time the patient breathes in, then likely that patient is hypovolemic, or can at least tolerate fluids. But it also means that it is very unlikely that they're in obstructive shock, very unlikely that they're in cardiogenic shock if their IVC is very small and collapsible. The final thing to check in this rush exam are the pipes. So the abdominal aorta can be another source of bleeding if it ruptures, if it dissects. You may not catch a dissection, but we're just looking for free fluid with a fast exam, and then we're looking for a AAA. And if you rule out a AAA, then at least you've ruled out that cause of shock or hypotension. Also, thinking about PE, pulmonary embolism, as a cause of shock and hypotension, we look at the heart to compare chamber sizes in the apical forechamber, but we also can look for DVTs, and that can further reduce our probability of this patient in shock being from a pulmonary embolism. So we're not going to go through the entire rush exam. We're just going to review a few things because you can get each part of the exam through other lectures: cardiac, aorta, lung, DVT, fast. You can just read those and listen to those individually. And it'll be a little bit easier than listening to a very long lecture. But let's review a few things. So you can get many views for the cardiac exam, for your echocardiogram, but for the rush exam, we're primarily just going to do the peristernal long and the apical forechamber. We can get what we need just with those two views. So first, look at a normal peristernal long view. You can see the contractility looks normal. This mitral valve is coming up and hitting the interventricular septum every time, indicating a normal ejection fraction. There's no pericardial fluid here. Along the pericardium, no pericardial fluid here. Compare that to this view where you can see a pericardial effusion. You can see this fluid snaking in right underneath the heart and right above the descending aorta right here. And you can see a little bit of fluid up top. Here's a very large pericardial effusion. So one that's obvious on exam, and if you have right ventricular collapse, so here's the free wall of the right ventricle, and if that collapses in during diastole, during when the heart is trying to fill or when the mitral valve is opening, then that's a sign of tamponade, and this needs emergent pericardiocentesis. One more example of a normal ejection fraction here, peristernal long view. You can see that mitral valve here coming up and hitting the septum every time. And then just compare that to this heart that has a severely depressed ejection fraction, hardly any muscle contracting anywhere in this heart, and this mitral valve right here barely opening at all. Now let's look at a normal apical forechamber. Here we have the left ventricle, right atrium, left atrium. You have mitral valve in the middle, tricuspid valve next to that. And this right ventricle, remember, should be 2/3 the size of the left ventricle. If it's larger than the left ventricle or the same size, it's abnormal. So here you can see that this left ventricle is actually smaller than the right ventricle, and this right atrium is huge. This person has really high elevated right-sided heart pressures in the setting of pulmonary embolism. Another reason to do an apical forechamber, you can see effusions. And here we have something called the McConnell sign, where you have a small effusion here. Left ventricle again, right ventricle, left atrium, right atrium. And in this small, it looks like a small amount of fluid, but you can see that his right ventricle is just collapsing in every time the heart tries to fill. That's called a McConnell sign. It's sensitive for cardiac tamponade. Now here's a normal IVC. The right atrium is here, and the IVC is coming out this way. And every time the patient breathes in, the walls of the IVC here just touches. And so this is probably normal, but this is a patient that certainly could get some fluid and I think be just fine. Compare that to this IVC. So this one is huge. It's not moving at all. Very distended. And here you see an effusion around the heart. So this is a case of cardiac tamponade. This is what the IVC looks like in tamponade. Another important part of the rush exam is the FAST exam, or focused assessment of sonography and trauma. And just recall that you need to look in all four quadrants. You're already going to look at the heart for the rush exam, but you want to look in the right upper quadrant, left upper quadrant, and pelvic views if you can to look for free fluid. So this is the right upper quadrant, and the liver here, kidney here. This is Morrison's pouch, or the patellorenal recess, this potential space between the liver and the kidney. And this little anechoic or black strip is free fluid. Below it, you see the spine. There's those bright white things coming through. And then this little bright thing here next to the liver is the diaphragm. And looking above that into the hemithorax can tell you if there's a hemothorax present. Another example of a positive fast where you got liver here, kidney, diaphragms here, kind of an overgained image, but you see this anechoic or black strip in the hepatorenal recess indicating free fluid and a positive fast exam. Also notice there is pleural fluid or possibly hemothorax present. In the left upper quadrant, you want to see both poles of the spleen, so here and above the spleen as well, because this area between the spleen and the kidney is relatively adherent. You're not going to see fluid there typically. It's a little different than the right upper quadrant. So take this example here. And we had to scan all the way over and go posterior in the patient. We didn't see fluid initially, but when you go to this inferior pole of the spleen and go very posterior in the patient, you see a little bit of free fluid right there at the tip. And notice we're still looking at the diaphragm here and making sure there's no hemothorax. So once again, a little fluid right there at the tip. Here's the superior pole of the spleen right by the diaphragm. You can see free fluid there as well, indicating fluid in the left upper quadrant and a positive fast. In this sagittal view of a female pelvis, you can see free fluid in two locations. This is the bladder in the anterior location, and then you see uterus coming in and out here right in the middle, and there's free fluid in this space between the bladder and the uterus, vesicular-uterine space, and then also behind the uterus, known as the pouch of Douglas or the uterorectal space, right here, anechoic free fluid. Now recall in the lung, we want to evaluate the most elevated portion of the chest because that's most likely where the pneumothorax is going to be. And you're going to find, when you're looking in a sagittal plane, which is the easiest thing to do, and what I recommend, you'll find a rib and it'll shadow. You'll find another rib and shadow, and you're looking at that space in between. Right below it, you can see a line. It's a bright white line, and that's the pleura. The pleura will typically slide back and forth. You'll see that movement here, and you'll see these comet tail artifacts coming down. And those indicate normal lung function and certainly rule out a pneumothorax. When a patient does have a pneumothorax, you'll still see that rib with shadow, and you'll see that pleural line. You'll see A lines because there's just air in the chest, but there's no sliding and there's no comet tail artifacts. So this person has a pneumothorax. So besides hemothorax, another place you can lose fluid is in the interstitial spaces of the lung. So you can have pulmonary contusions or just have flash pulmonary edema. And this is what a normal lung looks like. You have sort of pleura and rib shadows, just like we saw before. And there's A lines coming down, 1, 2, 3, 4, 5 A lines. And nothing looking abnormal. Compare that to this, where you have ribs with shadow, but now you have these bright flashlight-like lines going vertically rather than horizontally. Those are called B lines instead of A lines, and those indicate interstitial disease. In the setting of trauma, you would think those would be pulmonary contusions. Or it could be pulmonary edema from another source, such as heart failure. Now let's quickly do a review of the pipes. Let's first look at the aorta here. So we have vertebral shadow here, vertebral body. That's sort of your landmark. You have the aorta sitting right on top of that, IVC to the patient's right next to it. And the most important thing is you want an proximal, mid, and then infrarenal view, or a view right above the bifurcation into iliac vessels. And they all need to be less than 3 centimeters in diameter. We want to measure the anterior-posterior diameter. You can also measure in the longitudinal plane. So this is vertebral body, this bright thing in the back, and then you can see aorta spanning out in a sagittal view of the patient. Here's an example of a AAA. It's a very large AAA. You have a lot of intraluminal clot with a lumen in the middle. So make sure you measure this whole diameter here to get an accurate measurement. Another example of a large AAA, large intraluminal clot with a lumen here. So you have to measure here from the bottom all the way to the top. Very ominous looking AAA here with clot that's just floating with every beat, just begging to float downstream. And finally in pipes, we have the DVT study. Now this is a rapid exam we can do in the emergency department. It's not perfect, but in a setting of shock and hypotension, it may be the best we can do. So it's a 2-region compression test. You're going to compress several times in the femoral region around the inguinal canal. That's just distal to the inguinal canal. Here's an example of a common femoral vein and a saphenous vein. There's the femoral artery right next to it, and it compresses 100%. That's what you're looking for. If it does not compress 100%, then there's probably a DVT there. After you've done that first region, you go to the second region, which is in the popliteal fossa. Here's the popliteal fossa. You have artery deep, vein superficial, and we compress with our ultrasound probe, and we see 100% compression. Another example of 100% compression. Here's one example of a DVT. We are compressing this vein right here, and every time we do, there is still something in there. It is not compressing 100%, and there are intraluminal echoes, so that is a DVT. Another example of a DVT, when we compress, even though we have some Doppler flow, power Doppler flow going through there, we still have two vessels here that have intraluminal echoes.